Morning, everyone. We're just going to make a start, or it's afternoon now, isn't it? We're going to make a start. There'll be a few people drifting in, but let's get started so we've got time to get through things and also for you to have a chat with each other. Quick introduction from us before we get started. I'm Sean Mayer. I work in the Scottish Government as a professional advisor for person-centred care.
I'm Rachel Wilson-Lowe. I am the Health Services Researcher for the Excellence in Care team at HIS.
Welcome, everybody. I'm Ben Watson. I'm the Senior Improvement Advisor for the Excellence in Care programme.
So the three of us have been involved with a task to try and develop a person-centred measure for the Excellence in Care framework. And so I co-chair the group with Gillian McCauley, who's Acute Director of Nursing in Lothian. Ben is the, what's your proper title, Ben, again, did you say?
Senior Improvement
Advisor, looking after, making sure it all happens and goes where it should go. And Rachel is a kind of some brains really that we have.
Just a professional Googler.
So we're going to share with you, first of all, there's the housekeeping details on the screen in case you need them. I'll just pause for a moment, let you read those. Welcome to those of you online as well, actually, while we're doing that to this session. It's good to have you with us. We've got people monitoring chat and so on, so questions, pop them into the chat, those of you who are online, and we'll feed those into some of the discussion elements of the session as well. Here's the objectives for this session: to develop some knowledge of the person-centred concepts and measures, to review and reflect on the framework that we've developed. It's very much in its early stages, and then also to have a think about the use of qualitative and quantitative, because often we rely heavily on quantitative. And for this, we need to very much have qualitative data as part of this measurement approach. So without further ado, I shall hand you over to Ben, who's going to just do a bit of an intro to the Excellence in Care programme.
Thank you very much. So in terms of the Excellence in Care programme, I'm hoping that you've all heard from it, of Excellence in Care, but just to give a little bit of big background perspective on where we've started this journey from. So as you've already heard this morning, a lot of our improvement work tends to come from learning that we've had elsewhere. So unfortunately, sad background behind Excellence in Care was from the Vale of Leven inquiry. For those who aren't aware of the Vale of Leven inquiry, it was in 2007, there was a C. diff outbreak in the Vale of Leven hospital. And following the inquiry, it was found that at least 34 people lost their lives due to systemic failures from government level all the way down to the most junior healthcare provider. So very, very sad in terms of where our backgrounds come from. However, what we're trying to do with Excellence in Care is provide that assurance that these things won't happen again. So there's a couple of bits that just pulled out from the inquiry there. This top left quote in particular really resonates with me every time I read it. But there is a need to ensure that individuals, there's a need to ensure that no matter where the individual accesses healthcare services in Scotland, he or she experiences person-centred, safe and effective care every time. So in terms of our Excellence in Care programme, we work very closely with the families of the Vale of Leven, and what we want to do is provide that assurance from that board level all the way down to the point of care where this is being delivered. It's about delivering high quality care. It's predominantly from nurses and midwives lens, although we have had recent discussions with the Scottish Government where we are looking to start moving into multidisciplinary teams. As we know, care isn't just delivered by nurses, midwives, although they have a massive part of it. It is about a whole system delivery and best outcomes for our service users. And most importantly, it's about that every time, everywhere. So just look at the right-hand side there. This is our assurance framework for Excellence in Care. Now, if you look at the elements, there's probably, I would say, most things that have already been mentioned this morning, if not all of them. And there's nothing that stands out and you think, I can't believe you've solved world problems there. All these things are talked about every day in healthcare. What we're trying to do with Excellence in Care is how we use those to provide assurance and how the relationships of these things work together. Just going to go in a little bit more detail in terms of this central part, and hopefully you'll start to see how some of these things connect with Scottish Patient Safety Programme and the Essentials of Safe Care, which we've already touched on, but also that QMS model, quality management system, and how these all fit together in terms of that delivery. So the central part in this in particular, so the fundamentals of care, person-centred care, compassion and communication, we're all kind of linked in there, but these are really, really the things that stood out from us based on the conversations with the families of the Vale of Leven. Fundamentals of care, these are often referred to as basics. We know in healthcare things You know, even the simplest of things that we on paper can be quite complicated. But we refer to these as a fundamental. So make sure that we're getting these right. So make sure that, you know, people's weights are taken on time, their medications are there on time. The compassion side of things sounds obvious, but how we treat people, how we speak to people, and how that links to person-centeredness. And in terms of that communication, so one of our family members talks around when he was in visiting his mum, who he lost during the Vale Leaving inquiry, Vale Leaving outbreak, sorry. It was very difficult to understand what was happening with his mother. He was either catching staff coming off shift or coming on shift, and they weren't quite sure what was happening. So that communication, that importance between linking the service users themselves, their families and loved ones, and the healthcare worker. And the last bit is that quality plan and quality improvement, how we use that information and take that forward. We did have a measure around person-centeredness originally, so this is one that we started out with, and we've reviewed this measure based on feedback from our service users and experts. And what we realised was what matters to you, although it's a massive important thing, it's a fantastic piece of work. We've basically taken something which was very, very qualitative and wedged it into a quantitative measure, basically losing the ethos behind what matters to you. So a little bit of feedback there again. This is only one part of it, it's a small part of it. But what we need to do is take that back to the drawing board. And this was agreed by our programme board to say we're going to take this back, going to have a look at it, but also understand how we would use that qualitative and quantitative information. Just going to pass over to Sean, and Sean's going to take us through our journey so far.
So thanks, Ben. So what we did then was we recognised that it's not that we didn't know this, we did know it, but we were kind of pushed into out of pragmatism and necessity, pushed into trying to find one thing. And for something like person-centred care or a person-centred approach to care, you need a framework approach. So we don't want something that's got 100 elements to it, but we need something that's got a couple of more dimensions to it than just a single quantitative question about, did people ask you about the things that mattered to you? And where we recognise that we need to focus our attention currently in the system, from what we learned from the Vale of Leaving families and from other data that's available, is at the top of this circle here, where it says attentiveness and attunement. And when you look at, whether you look at Vale of Leaving, whether you look at mid-staffs, if you look at Lucy Letby, a more current one of the things that was lacking in those systems that could have picked up problems sooner, had there been better attentiveness and attunement, was if there had been better attentiveness and attunement in the system. If we'd been listening better and more systematically, and we'd been attuned to the things that were going on, then we would have got on much better and picked things up sooner. So we were interested in looking at a measurement approach which would help us to assess and evaluate how attentive are we being and how attuned are we to the things that are important to patients and families using health and care services. So we did a bit of a concept analysis. Now, Excellence in Care was already using the picture that's on the left of the screen there, which is the McCormack and McCants model for a person-centred system. And this has been around for a long time. It's very comprehensive. It covers all of the important elements. But actually, if you were to try and develop a measurement framework around that, you'd have tons and tons and tons of stuff. And we haven't got the opportunity or the capability or capacity to do that at the minute. What we need to do is start somewhere and build from there. So we looked around to see what else was out there. We looked to see, if you like, for something that was a synthesizing approach to person-centred care, to understanding what its components were. And we came across this person-centred research carried out by the Health Foundation, which is what's on the right-hand side of the screen there. And this zeroes in very much on the care activity itself. What are the components of good person-centred care at the point of care? And so what you see there is you've got dignity, compassion, respect. That's that humanity, human rights, if you like, fundamentals that should wrap around everything that we do. But then very specifically, there were these elements which align kind of to person-centred activities. So personalised, so that might be things like shared decision-making or what matters to you conversation, personal goal setting, personal outcomes, all of those types of things. Care is coordinated, so that's how well the bits of the system working together around the person and the things that they need, and also with each other around the person. And then the third element of the pie on the Health Foundation image there, enabling. So you know, are these things helping the person to have agency and a bit of control and have a say in their care, how it's being provided, what's going well and what's not going so well. And what we found, there was quite a lot of alignment between this Health Foundation model here, or framework, and the middle, where we see that's the person-centered outcomes in the middle of the McCormack and McCants framework on the inside there. And so between these two, we kind of pulled together what we thought were the core elements of a person-centered approach to care. So on the one of the other things the literature was quite clear about was the importance of separating person-centered activities from person-centered outcomes. So often in healthcare, particularly, we get a bit confused, or we conflate the things we do to help care be more person-centered with the person-centered outcome itself. So, for example, personalization, when we listen to people carefully, it helps us to identify the things that are important to them, which then in turn helps them to get a good person-centered outcome. They feel better, they have more control, and so on and so forth. So any measurement approach needs to recognize that there's person-centered activities that we should expect to see in a person-centered system. So lots of things, some stuff about personalization. We see stuff that helps to coordinate care. We should see stuff that helps to enable people. So, for example, good health literacy, techniques being used that give people a voice, give them understandable information, help them to make the right decision for them. So those are activities that we would do. And then on the outcome side, we would see people feeling physically, mentally better, coping better, being able to do the things that are important to them in their day-to-day life. That's that what matters to you stuff. And also on the experience of care side, having a positive experience of interaction with health and care services. So those are the outcomes. Over there, well-being and experience of care, and on the activity side, we've got personalization, coordination, and enablement, and all of the things that go with those. The other key thing that we recognize in this, and this was very clear in the literature, is that if you only have a 5-question survey for person-centered care, you are not going to get to the heart of the matter. You're not going to properly understand whether the care that's being delivered in your system is person-centered, and you're not going to understand whether people are getting those good person-centered outcomes. You need to have qualitative data in the mix here with this. So, for example, on the person-centered processes side, you can use a bit more quantitative stuff over there. So you can use sort of survey type approaches to sort of ask people on a scale of 1 to 5, did people listen carefully to what you were saying? That's a kind of person-centered process thing. But then to understand whether they are able to live life in a way which gives them meaning and purpose, that's quite difficult to find a number to tell you that. You need qualitative data, you need narrative, you need to observe, you need to interview, and all of these types of things. So that's how the framework is looking. These are the things we're going to develop some measurement around, probably some more quantitative survey type stuff, maybe a short form 8 to 10 question survey around the items on the right-hand side of the table there, and then more qualitative data, so it could be like care opinion, observations of care, these types of things, to look at the outcomes on the left-hand side of the screen. And we're going to talk a bit more about the qualitative stuff in the second half. But what we want to do is just pause there. That's good. We're going to pause here. And what we want to do is on your table, give you an opportunity just to have a chat with the other people on your table about what we've been talking about and what you see on the screen there in front of you. Do these things. The questions are on the next screen. You've got these questions on your table. I'll put the slide back up again in a minute so you can keep looking up at it. But these are the questions we want you to think about. What do you think of the measurement framework components? Do these seem to cover the important bases? Would some data, qualitative and quantitative, on these things be useful and meaningful to you in the carrying out of your day-to-day work? And is there anything missing or anything else? So we want you to have a chat about that on your table. Online, what have we got online? Have we got a
rooms, so we've got a small breakout rooms, we'll get a Jamboard as well.
Okay, so on those of you online, you're gonna go into breakout rooms, and then there'll be a Jamboard for you to put stuff on as well, and we'll try and feed some of that back into the room too. So we're going to give you about 8 or 9 minutes or so now of, say, 8 minutes of chat on your table around those questions or anything else you want to talk about relating to the framework, and I'll put that back up on the screen again there for you. Okay, over to you. On the tables, if there's key points you want to capture, stick it on a post-it and put it on the flip chart paper so we can capture that from you, because we're using this conversation to help inform the framework still. It's still in that stage where it's being developed. So. Thank you. Okay, the breakout rooms are just closing down online. So if I could ask you just to finish your sentence, and then we'll have a couple of minutes. Just anybody want to share? If I could ask you to write down any key points from your discussion, put them on the post-its. I can see some of you have done that, because we'd like to capture some feedback from this session, which we'll use in our ongoing process of developing something. We've just finished, or we have just actually finished this week, an expert review is closed. We're just analysing the data from that. So we're getting academics and experts in person-centred care and person-centred measurement from all around the world to look at this and tell us what they think of it. But we also want sensible people like you, not just academic people, to look at it and tell us what they think of it. Because what we want is, at the end of the day, is something that's useful and meaningful to the people who are doing the work, not something that's academically perfect. You know, a sort of a very purely refined measurement instrument. We want something that can be used in day-to-day work and that produces useful information in day-to-day work. So you can ask that question. That question, well, is care safe? We can ask that question, is care person-centred? Because safety, person-centred, effective, they're all inextricably linked, interrelated, and we need to have information on all of those things simultaneously with the same profile in the system, because at the minute the profile is kind of skewed, isn't it, between different bits of things that we measure. So any thoughts, reflections, feedback from the room? Take a couple of points from the room. Well, people who are online, if now you're back into the main room, we can't see the chat from your breakouts, but if you put your comments in the chat now, the people who are facilitating the laptops over the other side of the room there will be able to feed some of your key points back into the room as well. So please pop your comments in the chat. We'll come to those in a moment. In the meantime, let's come to the room. Anybody got anything they'd like to share in the room? Just put your hand up and wave. Karen. No, speak into the mic so the people online can hear you. Well, your voice is loud enough, but not for online. It doesn't go onto the internet. No.
Press the button.
That's
There
it.
you are.
Yeah.
Here I am. We were having a wee chat about, so we have got a lot of data in the system that we don't really harvest. So complaints is a key, piece where we're continually getting feedback. However, are we satisfied that we're really drawing out the thematics of the experience of people that have come through the service and making that meaningful back into the system? So how do we then engage with teams so that they can understand, what's happening in my department, ward, hospital system in terms of kind of where's the Pareto of that? How do we break it down and then the improvement actions follow? I think we're not as good at that as we could be. And I've worked in a few boards and I'm not convinced we've got it right just yet. So it's probably just a piece of work that would really help around this.
Point, and Rachel's going to be dealing with some of that in the next bit. Yeah, that's great. Great question. So hold that, and we'll hopefully some of what Rachel says, and then we'll have another discussion opportunity after Rachel's input to come on to some of that. Any other points that people want to share back from their discussions? Anything from online you want to wave? Just wave if you've got something to share online. Yes, over
here. Hi. So the discussion point there about what do you think about the measurement? And it was interesting to learn that there's an expert group looking at this and that we are sensible people, but actually, as a group, we actually thought it was really important, and I'm sure you've thought about this, but actually, what do patients and people who use our services, what do they think about this? What does that capture what person-centeredness means to them?
Yeah, so that's a great question. So if you like, the first step was to listen to what the Vale of Even families said. So they said the relational elements of care were one of the things that was missing. And I think the term person-centered was used probably because they'd heard it. But so they thought in fact, person-centered, I think I'm right in saying, Ben, threaded through everything that they talked about, the Vale of Even families. So it's primarily a system failure and breakdown, which led to safety issues. But if you ask the families what it was that was missing, what they kept talking about was the relational elements of care were the things that were missing: communication, compassion, listening. So that was the starting point for this. And then we've developed this. This will go back to those Vale of Even families as well. And also then we'll start to test it in the real world. Once we've got something that we think's usable to test, it'll start getting tested with people who use services and see whether it's meaningful to them. Do the questions as we come up with questions to ask them, or a qualitative data framework analysis, do these things make sense to you? And are they the important bits of care?
We also have marker on.
Yeah, and we do, and that's right. In our group, we have the sort of patient voices in the group that's developing the measures as well, which always brings a different perspective to our sort of professional heads. Yeah, Susan. Press and hold. No, oh well. Batteries. Your batteries are flat. Yeah, pass your one over. Nice.
I'm just very aware that there's some good folk.
Yeah.
So what always worries me is when we're trying to do something for a whole system service is that the service that I currently work in is mental health, and it's the one that gets left at the back, and it's like, oh yeah, we better think about some mental health stuff. So it's just to make sure that that's at the forefront, because that's one of the hardest areas to get patient feedback from and to get that qualitative data.
Yeah. Okay,
When
that's
you're
a good point. That
something.
should be sort of an early test area for us, I think. So we should capture that. I can see there's comments coming in online. Yeah, do you want to let's make sure we include. There's a couple I've seen flash up on my screen here. The clicker's not working again, by the way, just so you know, they're over there as well. I'll give you a technical. No, not yet.
Can you hear me now?
Yes, I can hear you now.
So we had a comment from Laura Keogh, and Laura was saying in their breakout that they were discussing the importance of gaining feedback in a way that allowed honest answers from people experiencing care with relation to the person-centred outcomes. They wondered a little bit around whether the process measures will have individual questions which we might choose to focus in on as an improvement team. For example, perhaps coordination could be more of an issue in some areas, and enablement could be the, I think it finishes there. So I think around coordination issues, yeah.
No, that's good. That's a great point. So I think, yes, the plan is that this is going to be obviously used for evaluation and assurance, but also it's very much the ambition that this data should be sit in a place and be collected in such a way that it can be used for improvement at the ward level. That's one of the sort of primary objectives that we were given, that this must be usable at a team level. So it's not just about providing that big high level assurance. It's got to be useful. So there's a bit of compromise required to do that, but that's certainly high on our list of priorities as a must do. Those points were good. No, you got another one?
There's another point, and it's from Emma. In their room, they discussed possible future push on a more person-centred approach post-COVID inquiry. They also acknowledged that staffing and system barriers can currently challenge with that.
Yeah, so I think there will be, I think one of the things that we noticed went very quickly as soon as COVID hit was, for in hospitals, for example, we were absolutely certain we could make it safe for the student nurse, the cleaner, the nurse, the doctor, the physio to see the patient, but oh no, you can't have a family member to see you. So that's a big down. I appreciate it's not as a sweeping statement, but there was a very significant mismatch for me as a person-centred lead, thinking, how can we make it safe for umpteen hospital staff who are going between many, many patients to see them, but you can't make it safe for just at least one person a day to come in and see that person. So lots of challenges there. Thank you very much for that. We're going to hand over without further ado to Rachel, and the clicker is working. I'm going to skip that slide. Shall I leave that one? Do you want that one?
No,
just go there. There you go. It's all yours.
Thanks. Great. I'm glad I'm not being tested on my memory. I was a bit concerned with that, with the slide clicker not working. So basically, I want to talk about why we think having a qualitative approach to person-centered care, collecting data around this element of care is really important. And I think the questions today have really highlighted that as well. So I'll draw on some themes from that. So our aim is to develop a way to assist with the analysis and the reporting for health boards routinely gathered care experience qualitative feedback and data. So as Karen said, there is a lot of material already out there that a lot of us researchers would like give our eye teeth to have our hands on, and you guys have, but there's maybe not that knowledge or that systems enabled approach to analyze that data and to use it for both improvement at the local level and for assurance at the higher up level as we go towards like the board and national levels. So why do we want to use care experience data itself? So we know that existing measures of measuring and assuring person-centered care, such as Ben talked about the What Matters to You measure that was on the care dashboard, which essentially asked, did you ask the patient what matters to them, yes or no? So those are generally from the healthcare provider's perspective, and that was an example of that. But these metrics that are from the healthcare provider perspective are inconsistently linked with positive patient outcomes. Don't get me wrong, there are plenty of articles out there that do find positive links, but it's not consistent, and it depends on what outcome you're looking at. Whereas if we look at the data that is more from the patient's perspective, they're reporting on it. If you ask them, did the clinician ask you what mattered to you and do something with it? That is more consistently linked with positive outcomes, such as patient satisfaction, such as shorter hospital stays, and fewer adverse events. And so why do we want to use qualitative data as opposed to kind of traditionally used quantitative survey data? Well, one, I'm a qualitative researcher, so I'm always going to advocate for that. But I think it's more the fact that it allows for an in-depth exploration of patient experiences. It is very context specific, which is really useful in terms of informing local quality improvement. For instance, if you're at, say, a ward in Forth Valley in my ward, there might be specific issues with coordination of care for your ward that wouldn't be applicable, say, to somebody in Highland in a different field of in medicine or nursing. It also, as I said, we already collect this data. So Karen mentioned complaints, we have feedback cards, we have the information on the care opinion dashboard, we have interviews with patients. So there's a vast amount of data that's already being generated, but maybe there's not a systematic way of dealing with it. It's also empowering for patients to be asked about their experience, whether that be through feedback, through having the care opinion dashboard, through personal conversations with staff and interviews. And again, it's a very persuasive form of data. Hearing that story from that patient, be that written or verbal, is really powerful and sometimes is easier to get the point across than saying, oh, well, they had a 4 on a Likert scale. Well, what does that mean? So we looked back to what was developed by a pair of researchers from HIS and from NES in 2017 and 2018, in which they developed a qualitative analysis tool to be used by boards in relation to person-centered care. So they engaged 3 different boards to look at how they currently analyze person-centered care, what their ask for support was, and what we could develop to help them analyze this. So this was Forth Valley, Lanarkshire, and Glasgow. So we first asked what the health, or I should say my colleagues first asked what the health boards wanted. So they wanted a tool to help with the analysis. They wanted something practical that they could use that wasn't a little bit airy-fairy as qualitative people tend to be. They wanted a set of codes that already existed. So in qualitative research, we'd call them a priori codes as opposed to something generated uniquely from the data, which is really valuable, but it means it's difficult comparing across time, across contexts, across boards, if everybody's generating their own codes. They wanted guidance on how to use these tools, how to actually analyze the data and kind of encourage and gain confidence in these qualitative analysis skills. And they wanted guidance on how they could use this data at both the local level and the board level. So the tool was developed by the researchers mapping out existing frameworks for patient experience data. And that's kind of similar to what we did in Excellence in Care in terms of the framework, McCormick framework and the Health Foundation framework. And as you'll see, there's a lot of overlap from what they've developed in this specific tool to what we've developed in Excellence in Care. They developed the actual tool to collect the data and to report on the data, and also the guidance for those staff. So this is the thematic framework that they came up with. So they have 6 points of care, we have 5, but in reality, there's a lot of overlap, which makes sense as we were both kind of looking at the literature for what already exists out there. So this is what they use. This is their higher kind of level themes with various sub-themes underneath this. And that's the kind of coding framework. So when you're reading that qualitative data, you can then say, okay, this line they're talking about, I felt it was a bit scary getting moved from here to there. I wasn't quite sure, might relate to kind of safe and effective treatment, for instance. So that's kind of what you're doing there. So they developed an Excel tool because Excel is a very kind of accessible and widely used software program in comparison to, say, something traditionally used in qualitative analysis like NVivo. And the tool basically allows the analyzer to break down that piece of text, be that something that's transcribed or something that was written by the patient themselves, into these different kind of themes or codes, and then also automatically generates charts and tables so that you can then kind of report back up at the higher level. And then they tested this tool in the boards and got feedback on it, and we'll talk a little bit about how that's still being used today in one of the boards in particular. So this guidance document that they created kind of went into what is qualitative analysis, how do we do it practically, how do we use this tool specifically to look at the data at the local and the board level, and to inform service improvement. So this Excel tool allows the kind of local qualitative, very context specific data to be used by the local teams, but then also kind of quantifies the qualitative data on the back end for reporting up the structure to the boards. So say, for instance, you're going to code something as relating to patient safety. That comment made by the patient could both be indicative of positive, safe care that they experience, but also indicative equally of negative, unsafe care experience. So you'd say that comment about, oh, I felt a little bit shaky or unsteady, or I didn't feel safe in this aspect of my care, would be coded as a negative experience, a negative safety related experience. And then the Excel table just spits, or the Excel program spits out a table that you can then pull out and report to the higher ups. But also you still have that local level data to be like, okay, well, why in this specific context did that patient feel unsafe? And you can do a little bit more of a deeper dive whilst also reporting up the way. So today, the tool is still actively used in Greater Glasgow and Clyde by the patient-centered experience care team. Somewhere along that lines is the name, but Anne Clinton is the one leading that team. And they adopted it for their specific context, and it's kind of grown and changed. We'll talk a little bit about that, but it shows how useful this sort of kind of pro forma tool can be. So as I said, they adapted it to fit the local framework. They actually changed it from Excel to fit into their Datex software. And they used both the kind of already established themes while adding in some kind of subcodes that specifically were coming out in their context. So it can grow and change, but still, if you're keeping those larger themes, still allows that comparison across time, across context, across boards. And they applied they can pull a report, which was something really useful for them, for all the examples of a sub-theme, for instance, and compare it across a ward, across time. And that's a really valuable aspect of the tool that they've found, having that sort of longitudinal data as well to kind of look at improvement and how things are changing. So here's some quotes from Anne. They were able to download all of the feedback that's been collected, and it's coded against the sub-themes and also the tone of it. And it's all written into a report for the local team, but also it can be kind of spit back up into quantification of qualitative data for kind of assurance at a higher level as well. So some of the challenges they reported as well as that we've considered. There's issues around governance. So is Excel still an appropriate tool? As I said, this tool was developed in 2017 and 2018. Or does it need to be held on standard systems such as Datex, such that Greater Glasgow and Clyde has used? But granted, Datex looks different in every board. So that does raise some kind of, issues in terms of how that's implemented, whereas Excel is the same for everyone. You also need to have the staff with the analysis skills to actually go through this data. And I'm a firm believer that anybody can do qualitative data analysis, but it's more the confidence in feeling like you're creating the right code or this or that. So it's having staff have some time to play around with it as well. Reporting on qualitative data, although we have those tables, how kind of turning those tables into what that means actually, rather than just the numbers, can be difficult sometimes for people. So some guidance on that in terms of how do you frame this report so that it makes sense both for you at the local context, but also at the board context as well. There's different approaches to gathering this data, so making sure that it is still applicable for complaints, for care opinion data, for interview data. We want to make sure it's as appropriate for every medium as we can. And then we also obviously need to update, refine, and just make sure that our excellence in care person-centered framework that you guys looked at earlier that Sean brought up, how does that align and make sure that the codes fit with this thematic framework? So some slight chopping and changing will need to happen, but overall, how do we use something that's already exists and has already been tested across the boards and found to be useful for the purposes of excellence in care and assuring person-centered care? So discussion points, more breakout room time. So basically we're wanting to ask you guys, do you see that analyzing qualitative person-centered data could be useful in your board? How so? What potential barriers and challenges could you foresee to using this? I've obviously mentioned some, but I'm sure there are much more to consider. And then what factors would better enable you to analyze this kind of data? What support could we provide as well, both in terms of a guidance document and just the factors and the systems to enable this to happen? And that is me, and I will let you guys go to your breakout rooms, either in person or online, and then we'll have you guys back in 8 minutes. Okay, so that should be everybody coming back into the room now. Sorry guys, I'll come back again. So, shall we start with the in-person people here today? Any kind of comments on that from your group discussions that you guys want? Here we are, let's go to this table.
So I was part of the pilot in Glasgow when this was rolled out. So I worked at the Beatson. What was really interesting was to start with the ward staff collected some of the data, and then I was asked as a practice development nurse to go in and collect the data, and there was a real stark difference because people weren't as honest with the people that were caring for them and didn't sometimes want to give, because in 3 weeks later you were coming back for your next cycle of chemotherapy, and if you had, given that negative feedback, it didn't matter whether it was we won't be putting a name to this. People did give very different feedback.
Yeah.
I would say it was a really good tool. I loved using it actually. It gave great feedback. I would say it was really labour intensive. It could have been my full-time job.
Yeah.
But I think if I've got the right processes in place, it's absolutely the right way to go.
Yeah, and I think that's a really good point. I think in strictly kind of academic settings, when we're using qualitative data, we really do a lot of kind of soul searching and thinking about how does, who I am as a person impact the kind of data that's generated, and particularly for healthcare settings, how does my role as a caretaker kind of come into that as well. So I think now currently in Glasgow, it's being used by Anne McClinton's team. So people kind of a bit more outside coming in rather than the person directly providing your care. But I think, again, that will depend on what kind of data you're looking at. So if it's a complaints data, if it's from care opinion versus if they're gathering it, you're right. I think that's something we need to consider when moving forward, is how do we provide guidance on that, but also, enable kind of honest conversations. Maybe is that using somebody who's not on the floor usually when you are, not the person directly involved in it. I'm sure it'll change context by context, but providing some guidance around that is key. Thank you very much. Anybody else?
Oh, yeah. Just to make a point about what capacity we need and have in the system to best kind of analyse, interpret, contextualise the data that we're gathering and reporting, and make the best use of that for assurance and improvement, and not just relying on clinical staff to do so. So that there's a point in it, I think, more broadly around what does our workforce need to look like. How do we position, for example, data analysts in our service, people who are improvement specialists within our service, who work alongside and collaboratively with our clinicians, who are really properly making use of the data. We're not just dropping data into wards and units and inviting them to get on with it. So there is a capacity, expertise issue there in making sure we've got the right shape of workforce, which does include our people with that
Yeah.
type of expertise.
Yeah, I think there's definitely a place for kind of frontline clinicians in terms of kind of gathering and having these conversations about data, but I think it obviously would work best if you have a team of people, be that kind of data measurement advisors, quality improvement people, patient safety kind of team, who are constantly looking at this data, who are more kind of involved in it and familiar with it, to then go back and kind of have those conversations then with those front of line clinicians. So there's that kind of point about making sure everything is accessible and digestible, but also relevant to those clinicians. And we're not, here's another thing you need to do. Now we expect you to be researchers as well. So we definitely need to embed that in the system and utilize some of those existing kind of people in gathering and analyzing this data and reporting back.
And those, making sure we tap into those sources that have already been mentioned. So care opinion, complaints, there's tons of data out there already.
Yeah.
And if we've got things that make it easier to make sense of that data.
Yeah, and people who are familiar with that data in those boards, like the complaints teams.
I suppose there's a little bit as well around shaping guidance. So you talk about quantitative. It's about you have data experts at the top who deal with the numbers all the time, but you maybe need that little bit of understanding if you're frontline staff. So it's having that almost a hierarchy of who understands what. And I suppose it's the same when you look at qualitative information. I'll probably argue that qualitative skill sets and that analytic side of things is probably shorter than what it is for numbers.
Yeah. And I believe we have some people from online.
Yeah, some feedback from the online audience. So Damien has posted into the chat box in their breakout discussion. They talked about challenges, including driving engagement, getting people involved, working with the right group, enablers, having a number of ways to gain that trust and engagement, and also the importance of having a team behind you to do the analysis and visualising the feedback. And it's vital to feedback the positive points to staff, not just to focus on negative.
Yes, definitely. Yeah, I think that, as you say, like with that tool that is developed already, there is that positive, neutral, and negative. And I think so often we focus on the negative, and particularly in the safety context, focus on what went wrong, but also we want to be able to focus on what went right and what we can kind of further encourage. And I think when you're feeding that back to staff, in frontline staff in particular, that's really important, and that's where it's kind of really empowering to also celebrate those successes. So this sort of tool would enable those conversations to happen, as well as the kind of harder conversations about what needs improving.
Great stuff.
Next slide.
There we go. That's our last slide. So thank you very much, Rachel, Ben, and all of you. That's been helpful for us. We're going to feed this back into our next person-centered development measures development group meeting, or whatever we call it. I think that for me, one of the biggest things, and it was a theme that came up early this morning, was that the well-being of the workforce is absolutely key in delivering high-quality, safe, effective, person-centered care. And one of the most powerful ways that you can boost the morale and help the well-being of the people providing care and support is through letting them hear the impact and see the impact of their work. And actually this, for example, care opinion, 70–80% of the stories on care opinion are entirely positive. What processes do we have in place to make sure the teams who those stories about are hearing them? We don't really have any, and that's vital. So it's important for us to know that we're getting it right even in these current circumstances, we're getting it right most of the time. And when you know that you're getting it right most of the time, you're in a much better place then to tackle the things that aren't working so well. So huge impact and benefit here for staff well-being as well. So thank you very much, everyone. That's been great.
Everybody.
Thank you. Hopefully
Thanks, everybody online.